Okay, recording started.
It has started. Okay, I guess it doesn't make the little announcement. Hello again. Here we are. We're officially being recorded, the May 14th FTAC meeting, and I will turn it over to Pam McEwen, who will call us to order.
Thank you, Mary. It's now 2:04 p.m. and I want to welcome all the FTAC members and call our May 15th meeting to order. As Mary mentioned, we're now on Teams. I think we're starting to get to be old hands with Teams, but just in case, you have a material in your agenda packet with instructions on how to do everything. Next up is our roll call. So Mary, I'm going to go right back to you.
All right, thank you. These names are listed alphabetical by first name. So when I call your name, please unmute yourself and let us know you're here. Christine Eibner.
Here.
Eddie Rouser. Eddie Rouser. Okay, we can come back to that. Esther Lucero. Esther let us know ahead of time that she would not be able to attend today. Hiroshi Nakano. Kai Young. Matthew Morrissey.
Good afternoon, I'm here.
Okay. Pam McEwen.
Here.
Bob Murray. Bob, are you here today? Okay. Roger Gantz. Well, someone just joined. And Sarah Hewling.
I am here.
Okay. Perhaps we should go through this again. We do not at the moment have a quorum.
There may be some issue of people being able to unmute themselves too. I don't know.
Okay. Let me
I think
look down
Bob
the
may have
list.
just joined.
Oh, okay. So we'll go back to that name for the roll. Oh, and I see Roger. One moment. Bob Murray. Roger Gantz. Roger, are you able to unmute yourself?
I had trouble unmuting today and
Yeah.
I just had to go up to the top strip to do it, but I couldn't do it from my photo. So I don't know if anyone's having that.
Oh, yeah. Try there's a ribbon at the very top. And the mic is toward the right. It's near share and it's near the little red phone icon that says leave. But don't leave. Please don't leave.
Hello?
Please unmute yourself. Is that you, Roger?
It is. Thank you. Sorry.
All right, we got Roger. And I'm going to go through the list again. Folks may have had trouble unmuting themselves. We'll go through real quick and we'll turn it back to you, Pam. Eddie Rouser. Okay, I don't think Eddie's here. Hiroshi Nakano. And Kai Young. Okay, thank you. We have 5 out of 10, which constitutes a quorum.
That's enough.
Okay.
All right.
Okay. Thank you.
Yeah, thank you, Mary. And I'm hoping people will be joining a little later. So now the next thing is to adopt the March meeting minutes. Does anybody have any concerns or questions about the minutes? Is there a motion to approve?
Motion to approve?
Thank you. Is there a second?
I'll second.
All in favor, say aye.
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 Any opposed? And the motion is approved. Next, we have public comments. Mary.
All right, thank you again. Since our last meeting, we did not receive any written public comments. Usually we put those in the packet, and between 2 weeks before our previous meeting and 2 weeks before today, we did not receive anything in writing. March 6th to April 30th. Those are our dates. You can listen to the comments that we heard during the March meeting. There's the timestamp to it. And you can always provide public comment orally during meetings. We start out with people who signed up ahead of time, and then we open it up to folks who want to put up their hand. So we will start with the first person who signed up, and that is Rachel Snell.
All right, can everybody hear me okay?
Yep.
Okay. All right. Good afternoon, members of the Universal Healthcare Commission's Financial Tech Advisory Committee. My name is Rachel Snell, an organizer from the 37th Legislative District. I'm here to ask you to include dental and vision insurance in Washington's Universal Healthcare carve-out. I have good health insurance, and I still have to pay an insane amount of money for dental care. So do many people in my community. Dental insurance is consistently under-discussed, and high out-of-pocket costs are a major barrier for us. Washington's Primary Care Transformation Initiative is already advancing integrative primary care with advanced capitation-style payments and team-based models, including behavioral health and community health workers. This carve-out proposal builds on that one consistent measure set: prospective payments to providers, urban-rural adjustments, and tracking ED use, admissions, and chronic disease outcomes. We currently spend 4.7% of healthcare spending on primary care, and the goal is to increase that by 12%. So covering dental health insurance is a way to increase that coverage. Thank you for your time, and thank you. I yield the floor back to you guys.
Thank you for your comments. And I should mention that we did get some feedback about, again, what Pam was mentioning earlier about unmuting. Sometimes it's not immediate. So I think what we're going to do is give a lot of people the ability to unmute. And then, if it's not working for you right away, we'll go to the next name and then we'll come back. So that way we will get everybody who signed up ahead of time. The next person is Sherry McAvoy.
Hello, my name's Sherry McAvoy, and I am testifying today on behalf of the Healthcare for All Washington. And I did the same comment to the UHCC. And we recommend that the FTAC consider the following 3 options for using the $250,000 generously provided by the Office of the Insurance Commissioner to fund research to further the UHCC Commission's work. One is to complete the actuarial design analysis to allow the commission to complete a set of benefit designs for the legislature. The Milliman model previously done needs to be revised to model the Uniform Medical Plan and the Essential Health Benefits Benchmark Plan for all enrollees, regardless of income, and do premium estimates at 100, 95, 90, and 85% actuarial value. And 2, economic modeling to estimate the type and amount of revenue tax sources needed system, including analysis on existing funding levels and sources for health care coverage in our state, including ERISA, Medicare, et cetera. And to unify our state health programs to lay the groundwork for a universal health care system in Washington state. For example, making all plans of the Health Benefit Exchange public option plans. And we also support the OIC conducting research regarding how the creation of a universal primary care system could be implemented and what its impact on the overall health care system in our state would be impacted. Thank you for your consideration of these recommendations.
Thank you. And if I could return for just one moment to the roll, I believe Bob Murray has joined. Bob, if you can unmute yourself and just confirm that you're here. All right, more unmuting adventures today, but Bob has joined us. The next name of the person who has signed up is Jordan Despain. And my apologies if I mispronounced your name.
You said it just fine. Yeah, my name is Jordan Despain. I'm a family doctor in Central Washington. I'm grateful for the work that you are doing to bring universal health care to the state of Washington. I practiced in New Zealand for almost 2 years, and I can assert that the benefits of universal health care are meaningful and far-reaching. I would like to state my support for the Washington Health Trust proposed by Whole Washington. Having read some of the meeting packet, I would like to express confidence in the possibilities for reimbursement models in a universal healthcare system. In my opinion, a combination of fee-for-service and per member per month reimbursement would work well. I would like to suggest that there are also other mechanisms to influence physician behavior, including education loan repayment, which could be very beneficial in recruiting the increased number of providers that will be required to care for the influx of people that will happen with the introduction of universal health care. I'm working on reforming healthcare delivery in the system that I work in, and I'm optimistic for the possibility of revamping how we provide primary care and the way it's paid for in a universal coverage system. Thank you.
Thank you. The next person who contacted us ahead of time and who signed up is Chris Curry.
Hi, I'm Chris Curry, retired RN from Spokane and member of the Healthcare for All Policy Committee. I applaud the concrete work done on the draft reimbursement and pathway documents. They indicate some real progress. However, under step 2 of Transitional Pathway 2, HCFA would strongly encourage you to open competitive contracting only to administrative service organizations, rather than to all licensed health carriers or MCOs. We would like to see Washington follow what Connecticut did in 2012 and completely eliminate its MCOs after allowing their contracts to expire. The benefits include the potential of saving upwards of $1.2 billion annually, according to the recent PNHP report, which I hope you've all seen. Dramatically increasing transparency, substantially simplifying administration, greatly improving the healthcare work environment, strengthening the primary care coordination prospects, higher physician participation, and slashing ER and hospital admissions. This transition will also require staff time and funding, but a strong case can be made that it will be well worth the investment and that it will provide a perfect foundation for statewide single payer. Thank you.
Thank you, Chris. Next, we have Jane Grafton. Maybe it's taking a while for Jane's ability to unmute, so we will go to the next person, and then Jane, we will come back to you. Our next person is Thomas Kennedy. And again,
Hello.
There you go.
Oh.
Hi, Thomas.
Hi. My name is Thomas Kennedy, and I'm a volunteer with Whole Washington, and I am also co-chair of the Healthcare as a Human Right Washington Policy Committee. I want to give you and this commission some ideas around funding from the legislature. There are several bills that we had in this last session that could be used to fund these models. The first is the Washington Health Trust model, which is mostly through a payroll tax. Under universal primary care, employer insurance payouts would go down, so funding could fit into that niche. And under universal health care, they would definitely be eradicated. Second choice is HB 2300 or SB 6173, which is the Apple Health Employer Assessment bills. These are Medicaid abuser taxes, and I think these are a very natural fit for any sort of transitional solution. The third choice is HB 5808, which is taxing excess reserves of nonprofit insurers. This is a smaller vehicle that could help bridge the gap. The fourth choice is HB 2100, which is based on Seattle's excise tax on large operating companies with high wage workers. And this is a really good way to raise funding progressively. And the last choice is using and appropriating money from the millionaire tax, which has passed, but will not see the actual money coming in until 2, 3, 4 years from now for this. I hope this helps inform your discussion, and I'm happy to follow up on any of these after the meeting. Thank you.
Thank you. And let's go back to Jane Grafton. As we said earlier, it's probably easier to unmute yourself. If you look at the ribbon on the very top, there's a little microphone icon. If you click on that, the slash will go away. Okay, we can come back to Jane. That exhausts the list of the folks who signed up ahead of time. If you would like to make a comment, on that same top ribbon of Teams, there's a little hand. It says raise under it, and if you click on that, it'll light up and we'll know you want to make a comment. Okay, Matt Wright. One moment. Okay, Matt, you should be able to unmute yourself. All right, we are having bad luck with the unmuting today. Sometimes it just takes a while for it to appear on the user's side of the screen. So is there anyone else who would like to make a comment? We have Jane and we have Matt, both on deck.
Can you hear me now?
Yes.
Hello, FTAC committee members. My name is Matt Wright. I'm a resident of Seattle and a volunteer with Whole Washington. We've heard from the Healthcare Authority that 40,000 Washingtonians have already dropped healthcare coverage provided through the Washington Healthcare Benefit Exchange, with that number expected to rise toward 100,000 in the near term. A recent Healthcare Value Club survey shows that 2 in 3 Washingtonians report healthcare affordability issues. My family is looking at over $3,000 a month in out-of-pocket healthcare insurance premiums, more than we pay for mortgage. The situation for everyone is desperate. So when we're presented with anything that looks like a solution to this emergency, we get excited. Universal primary care delivered in an advanced primary care model sounds like a good idea, in part because it is the first clearly articulated model we've seen from the committee. Committee members have suggested use of OIC proviso funds to study universal primary care either as a standalone model or in comparison, side-by-side comparison with a universal healthcare model. I urge the committee to reject these approaches and instead look at primary care as one feature of service design in a complete universal healthcare system. If that feature becomes the first to roll out as part of a phased approach, each successive phase must be clearly laid out in a roadmap that gets us to the ultimate goal of universal healthcare. We can't build a foundation if we don't know what's going on top of it, and we can't know what's going on top of it if we focus entirely on one aspect of service design without considering the whole picture. Thank you for your time, and thank you for your public service.
Thank you. I think Jane Grafton may have just rejoined.
You betcha.
Oh, hi, Jane.
Hi,
Good to hear from you.
phone over laptop, more control. Yes, I'm Jane Grafton. I'm the new co-chair of HUX, on whom I'm commenting today, on behalf of whom I'm commenting today. The commission's deliberations about the universal primary care idea would benefit from expertise beyond the UHCC and the FTAC, and might benefit from including members of HUX as well as those who are experts in the community health center world. And in addition, I urge the commission to dedicate the OIC proviso to an economic study, echoing what Sherry, Chris, Dr. Despain, and others have said today. So thank you very much for your time.
Thank you, Jane. And thank you for your patience as we worked out the details of meeting on Teams. And is there anyone else who would like to make a comment? Okay, I think that closes our public comment period. Thank you, everyone. Reminder, we welcome and encourage public comment. We appreciate your feedback. You can always send us comments via email. That email address is hcauniversalftac@hca.wa.gov. During our meetings, we cannot accept public comment outside the public comment period, so we are closing the public comment period now. And the next agenda item is also mine, so I'm just going to jump right to it. Ross, if you could advance the slides a bit. There we go, the work plan update. This is going to be very short. It's good to start with this slide, which shows the charge of the Universal Healthcare Commission. There's two parts to it. One is to create immediate and impactful changes in the healthcare access delivery system in Washington. And then the other is to prepare the state for the creation of a universal system with unified financing. So we tend to shorthand these in the text you see to the left and the right to the transitional solutions and the universal system design. The next slide. This is where we are with all of those pieces. The universal system design. If you go to the next slide, Ross, we're going to drill down into a little bit of detail on that. This is what a lot of our meeting is about today. The green means the initial proposals have been approved. The orange means it's in progress. So provider participation and reimbursement, which some of our comments referenced, that is something that FTAC is working on. That's on today's agenda. Later today, Harrison will walk us through a draft proposal and a roadmap. And then the next thing up for FTAC is going to be financing. And then the bottom three belong to the commission. So that's where we stand on this work plan as we are marching our way toward the universal system design. And that is the end of those slides. I don't know if anyone has any questions about it. Okay, so Pam, the next section is yours. Oh, Roger. Did you mean to put your hand up?
Yes, I did. Just curiosity. I noticed some completion dates back on the slide.
Yeah.
Yes. For example, on FTAC for the completing the work for the reimbursement section and financing, is we have a target completion date for the second quarter of 2027. Is that, just to reconfirm, is that accurate at this time?
Yeah. And I'm looking at it and I'm realizing the provider participation and reimbursement is before Q2 of 27. The financing would be Q2. I mean, yes, they'd both be done by Q2 of 27, but we're expecting provider reimbursement to be done sooner than that.
Thank you.
Thanks. And now to Pam.
Yeah, thanks, Mary. Go to the first slide. So this is just a quick overview of the Universal Healthcare Commission meeting, which you'll see that their agenda looks remarkably similar to our agenda. So they discussed primary care, the proviso funding, and provider reimbursement. The next slide. The next few slides have to do with public comment. There was a really large group that turned out for public comment with, urging us to continue the work towards universal health care, people talking about individual issues related with our health system, and support for the reimbursement guiding principles, which I was happy to hear. Next slide. And then there was encouragement to go back to the governance recommendations from the November 2026 report. Then recommendation to design a universal system that does not include MCOs, which I think we heard testimony to that effect just a few minutes ago. And then urgency of providing care to those who are losing coverage due to recent changes in federal eligibility rules, which we also just heard someone referred to the 40,000 people who have already dropped coverage. And it's early on, there are going to be a lot more challenges to coverage in our state. So that's something that we're going to have to keep in mind as we go forward. There was support for universal primary care, but I think that there was a fair amount of confusion about what the universal primary proposal might mean, with and that kind of anxiety that it might displace work on a universal system, or confusion about how those things might work together. Is one is the universal primary care a transition to universal system, or is it something that's a distraction? There were questions about the proposal's feasibility, and then I guess then questions about cost, have the impact on cost and whether or not it would reduce costs. The discussion on proviso funding was similar. There were some comments about how the proviso funding should be spent to further the actuarial and economic analysis of a universal system. Some discouragement about using the funding towards understanding of the universal primary care proposal. Next slide. Then once we began the meeting, there was a really robust discussion of the universal primary care proposal. The presentation that came forward was very similar to what we heard. And I'd like to note that I think Hiroshi Nakano, Sarah Hewling, and Bob Murray were listened in as well. And I know Bob is here today, so they might be able to provide additional color commentary if we refer back to the meeting. And then I want to think this is helpful, which is that this is going to be ultimately the Universal Commission's decision about where to go with the universal primary care proposal. They may be back to us with more questions, but right now the ball's in their court on that issue. We shared feedback from our meeting, our questions and comments, and the commission members raised their own questions, lots and lots of questions, for really drilling into how the transition might be affected, or how that would actually work, definitions of primary care, many similar questions to what we had. And the decision was to pull a work group together that will go forward to start kind of delving into those issues. Hiroshi Nakano volunteered to represent FTAC on that work group. So many thanks to him for taking that on. And then we had a discussion on provider reimbursement. The commission approved the guiding principles, which was very exciting to hear. And then there was a lot of discussion about the payment policy. Lots of concern about impact on rural health, which we'll discuss further today, and issues about capacity and sustainability of the health system in relationship to the proposals related to provider payments. And I think that's all. Yes. So I think this is.
Hello.
Yeah, back to Harrison. I was looking at my agenda, Harrison. Who's
And if I
next?
could just jump in for a second, I want to note that both Eddie Rouser and Hiroshi have joined us.
Oh, good. Welcome. I'm
Yep.
glad they're here.
So welcome. Sorry to cut you off, Harrison.
Oh, no worries. Hello, FTAC. Good to see everyone again, and glad we have a full house now. So I'm here to talk about provider reimbursement. As Pam mentioned, we ticked off our first box along the way of these provider reimbursement work products. So guiding principles are now in the rearview mirror, and we are now working on moving forward the design element proposal, sort of the body of this work, as well as the implementation roadmap. Just to sort of remind everyone about what each of those documents are. The design element proposal, these are small recommendations, sort of general recommendations that could be implemented at a narrow scale and then broadened. The implementation roadmap, this was a proposal initially from Bob Murray that the commission accepted. And really what that is a more prescriptive, descriptive document that outlines potential pathways that will get us closer from where we are now towards a universal design and a universal system, primarily getting our arms around cost containment. We can go to the next slide. All right, so here is sort of where we are in the work stream of all of this provider reimbursement work. Progress to date, the FTAC sort of sub-work group has been hard at work since December or January, really hammering out the details of this proposal and roadmap. And that has wound its way back and forth between FTAC and the Commission. The Commission reviewed, again, the guiding principles, but also had a first review of the proposal in their April meeting. And since then, the work group has also drafted the roadmap, and I believe we have that in pretty good shape so far. So the documents we'll be seeing today hopefully are nearly ready for prime time, and we'll be talking about those in a little bit. So upcoming, in May, the revised work products will go in front of the Commission. Oh, sorry, we're in May now. We will be revising and discussing those work products before they go to the Commission in June for potentially a vote. You can go to the next slide now. Okay, so as we've talked about this and hammered things out and gone back and forth on several different issues, it's been apparent that there are some really important issues that are not within scope for provider reimbursement and are things that we'll touch on at other parts of this design process. You can see a non-exhaustive list of them here. One of them that we talked about and might be relevant for today's discussion is who oversees the payment system and sort of this governance issue. And that may come into play when we talk about how rural facilities are subject to some of these payment mechanisms. And the idea here is the governing body, however that may look like as would be defined in that governance design element, they would rely on the guiding principles that were recently approved and elements of this design proposal, but that would be a decision for later, and there are many other decisions for later. We have a lot of work in front of us. We can go to the next slide. So as Pam mentioned, we had a lot of good discussion at the Commission when we reviewed the design element proposal. And just to remind you all, there are several different sections of this proposal, which really is the main document that I'm hoping we can finalize today, potentially. And we start off with a summary and a background. That background, at request of, I believe, some FTAC members, focuses on explaining why this document is so focused on transitional solutions, and the answer there is really for reasons of the ultimate financial feasibility of a universal system. We next talk about these payment mechanisms, and broadly, these payment mechanisms break along two lines. You have the sort of pricing and spending regulation, and then you have another mechanism sort of pathway that describes how purchasing can be consolidated in various ways. When we talked about payment mechanisms with the Commission, there was especially one Commission member who was concerned about how these payment mechanisms may impact rural facilities, and I think we'll have some good discussion on that potentially today. I will note that they are currently carved out of the current legislation 5083 as it relates to PEB-SEB. And so this is definitely an issue we should consider. However, noting that especially these critical access hospitals and sole community hospitals are very largely carved out of those current reference-based pricing regulations. Okay, when we got to provider incentives, we received a question that essentially was along the lines of what would a provider opting out of these payment mechanisms look like. As we discussed in the work group, really for these payment mechanisms to get our arms around cost containment, mandatory participation does seem to be important. And as we'll talk about a little bit later, if designed correctly, those payment mechanisms and regulations could perhaps bring in the self-insured accounts as well. There are other aspects of this design element proposal that we may talk about, especially those relating to alignment with ongoing work, where we point to other work streams that are really important for all of the work that HCA is doing, but aren't necessarily, our bailiwick as we are designing this universal system. We can go to the next slide now. Okay, a little bit more about addressing concerns of under-resourced and rural providers. Again, as we currently have it, there is this carve-out within 5083 relating to pretty much all critical access and sole community hospitals, except for those that are part of larger systems. But things that we could decide on today and discuss today are, perhaps what other things beyond the guiding principles may inform a governing body's future decision to, potentially bring in those accepted hospitals later in the process? Are there criteria that should be considered that we could really lean on to ensure capacity and sustainability, as we know that those are really critical components? And then another thing is, as I think Bob built out his part of the roadmap, one thing that was included that wasn't spelled out in the design element proposal is the idea of an uncompensated care fund as part of a sort of stabilizing force that could mitigate some consequences from many things, including the fallout from HR1. Okay, I'll go to one more slide and then we can get into some discussion, I think. Right. I don't believe FTAC has seen the full scope of the roadmap document yet. That should be in, I believe, Appendix B of your packet. And this has a few different elements to it. We have our introduction, kind of describing what it is, and then two really specific pathways. One describing a pathway that relates primarily to hospitals and how we can deal with that spending driver there. Another that deals with how we can consolidate state purchasing as it relates to managed care organization contracting, or perhaps contracting more generally. And then lastly, addressing another question, another comment from a commission member. Our conclusion, hopefully, this is kind of up to you all, describes what success would look like. So, if we walked down both of these pathways, what would the end look like? How would it look like for facilities that are subject to these regulations? Would the overall system be more stable, more affordable for patients and the state? Those sorts of considerations. So with all of that, I'll pause here. We have quite a bit of time here, and I'm hoping that we can, in this time, walk through perhaps both of those documents, with the priority being on the design element proposal, to hopefully get that document or those documents finalized and in shape so that we can get them up to the commission at their next meeting. With that, we can open the floor, and Mary, perhaps you can pull up the design element proposal first, and we can take hands for questions or comments.
Sure. Ross, I'm going to steal the sharing. Let's see if this works. There we go. This is always dangerous, calling up this kind of document in the middle of a meeting. Oops. Are you all seeing?
It's coming through nice and clear.
Okay.
So again,
There we go.
Appendix A, Appendix B of your packets is where these documents live. And this is the provider reimbursement design proposal. I think it's in really great shape. It represents a lot of work by that work group, but would love to hear any comments that the group has at this time. I know we've seen it already, but I would love to hear more thoughts. And if we think it's in good shape to send up to the commission, that is an option too. Roger, go ahead.
Yeah, thanks, Harrison. I just want to reiterate in the section that deals with data. Hopefully that section is strong enough of a reference that we would build on the all-payer system that is under the jurisdiction of the Healthcare Authority today. I just want to reiterate that because we have a system we're trying to grow and build. It'll be a critical aspect for all analysis, and the point being is that is out there and live and well. So our work, and we talk about data collection and oversight, again would build upon and support those efforts. So
definitely,
hopefully
yeah,
that's
and
clear to folks.
Thanks for highlighting that. I feel like the current text gives a pretty good grounding in terms of the importance of the APCD. It does a few things to enumerate how that data could be used. Another thing it does is call out the need for a healthcare entity registry, which is, as we talk about aligning with current work, something that agencies are currently sort of looking into and working on, so that we can coherently sort of roll up all of that data into the organizations that are owning and controlling those facilities. So I feel like where it is currently, in my eyes, looks pretty good. Would be happy to take any potential edits, though, if there are any from you or others in the group. I'll mention one more thing, and I always give this disclaimer, and I forgot to give the disclaimer. Approving or moving these documents forward at this juncture would not mean that this is kind of our last bite at the apple, our last chance. This would simply mean that the commission has a chance to approve them as these initial design element proposals, and there will be a process later down the road where we can take those design element proposals, sort of align them all with each other, and make all and any necessary edits. I'm sure there will be many. So not necessarily our final chance, but with that disclaimer, I'll go to Eddie.
Yeah, so I know I haven't spoken with Roger, but I thought I brought it up that this is just one of many sources available, and depending on your task, it's interesting because it's an online platform that's more of a data lake versus some of the other sites that currently have data or that provide data. So it's hard to say that that's going to be a one-stop shop. It might live by itself as a great tool that actually brings many pieces of data together, but I don't know. I don't want to leave other data sources that are currently there not acknowledged.
Certainly. I think that's a great point, and we can add some footnotes and elaboration here so that we're not missing out on those. At my work with the cost board, the data call comes to mind, kind of a higher view of spending, capturing non-claim spending, which hopefully one day then APCD would capture. I don't know if others come to mind for you. And again, here thinking there's going to be a lot of data that's related to the system that might not be specifically guiding decisions and information on provider reimbursement. Perhaps clinical quality lives somewhere else. But do any others come to mind for you, Eddie? Sorry to put you on the spot. I see several hands,
well, I
so we
mean,
can go to
the
others
big
too.
one is the provider one data source that
Certainly.
is kind of the MMIS system that originally captures all the claims for Medicaid. And, that is a very good system that maybe gets to a high percentage of the cost, but then even that, that Milliman goes directly to the providers to get even more information. And then in that very detailed information, there's a lot of proprietary and non-proprietary. So it's kind of an interesting dilemma if you're there trying to forecast or set rates as to if you could take that data and then put it up into a data mart for everybody to see and not violate any type of contract language.
Mm-hmm. So yeah, just to sort of make sure I understand where you're going, we want to be comprehensive in terms of as comprehensive as we can be in terms of enumerating all these different sources, and also perhaps suggest some interconnectivity of them and accessibility of them to help the governing body make decisions. Is that roughly accurate? Fantastic. Let me see. I'll go in the order of hands I see. Sarah first.
Well, I love this conversation because we already have legislation around the APCD, and I would like to see that that's fully played out, much like we're trying to hash out some suggestions here and develop the policy based on directives through legislation. I would hate to have overlap. I'm not saying we should be limiting those sources out there, but I think having bifurcated sources potentially are a problem. And that's what the legislation around the APCD was attempting to solve. Because if you are in this business, it is a business. And so it might not need to be that way if we were to optimize the work that the legislation was intended to do, if that makes sense. I'm happy to answer more questions, but we don't have to go down this rabbit hole because I can.
I know a lot of your work has dealt with the APCD, so certainly one of our resident experts. So I guess what I'm hearing there is, right, currently we have all these sources. Ultimately, it would be nice if the APCD were something of a one-stop shop, if I'm understanding you correctly. Fantastic. Okay, Roger.
Yeah, this is a little bit of a follow-up to Eddie's. And Eddie, it's my understanding, just two pieces. One is that, at least in theory, everything that's in Provider One, that MMIS system, is sits in the APCD system. I granted Milliman gets other information from providers, but that information that Milliman gets doesn't sit in Provider One. Just as a reference, I understand it. But maybe more critically, given you sit in kind of a unique situation, and I'm thinking of a footnote here of other systems that we ought to, continue to be aware of, or at least footnoted. Could you provide that to Harrison, at least as a more comprehensive footnote?
Sure. And I mean, I know that I've looked in many systems, and it's a data lake that's transformed, so it's definitely not inclusive in terms of what is in the ODS and Provider One. And not that all those tables would ever make it there, because there are a lot of transformative tables that help aggregate it up to the level to get paid for by the state funding system. So it has, from a research standpoint, sufficient information in there, but it's not comprehensive.
Yeah. So I guess real quick, in my point of view, is if there are other ones that you can think of that would, expand upon this. I mean, one to me comes to mind, I'm back in the Medicaid world for a moment, is with the work that the Caseload Forecast Council does, right? And projecting caseloads. And obviously that doesn't sit in these systems, but that is certainly, seems to me, as we think about, the global system, another system out there that we would want to link to this. My only point being is, given your unique situation, if you could maybe footnote some examples of that.
That's an example where, the underpinnings start from ACES that go into Provider One, and then that system is moved to the CFC. Then the CFC provides a caseload that then populates many other databases. So, I mean, those strings of systems are in place, and those systems won't go away, but one system that can house all that information in a big format may attempt to put them all together, but it's of interest.
Mm-hmm.
I mean, and then on the funding side, so yeah, I mean, I don't. If you're looking for clinical data, if you're looking for transactional medical claims data, if you're looking for eligibility data, if you're looking for elements for funding state agency data, they all sit in separate systems, and they're all kind of on a continuum, on a path. And so it would be quite the nightmare to put them all together in some type of flow diagram.
Certainly, maybe that'll be Appendix Z someday, but for now.
Come on, Eddie, come on, you can do it.
I think I just heard him volunteer to do that. Did I hear him volunteer to do that?
Thank you, Eddie.
Thank you, Eddie. I second that.
So I guess from all that, it sounds like we're kind of a far way away from where we'd like to be in terms of an integrated database that's comprehensive. For other people's reference, I believe the rough estimation is that the APCD represents about 70% of the population in Washington State, so definitely missing a substantial amount. So I think my suggested action steps here are that within the text, we acknowledge that there are other sources, and that integration is, as much as is feasible, is critical. And then perhaps we can drop a footnote to some of those exact sources, so that we can make sure that we're covering our bases. Go to Roger.
Yeah, I agree. And just not to beat this one to death, but as Eddie said, this is transactions data, so it's on the cost side, but we have, cost, quality, and access, right? The golden triangle. And as we all know, probably the linchpin, and I'm forgetting the name of our, good Lord, our all-state, oh, Pam, help me here. It's the big HEDIS measure system that our state has. It's another example, right? I'm forgetting the name of that work. So there's a wealth of information on that one that's not necessarily directly reimbursement per se, but it is quality assessment information that will continue to be used for this universal system. So I guess what I'm maybe stumbling to try to say here is what we're articulating here is through maybe the lens of reimbursement, but we have other sides in terms of other outcome information that's critical. So maybe a footnote acknowledging this focus and the fact that there are other ones. I'll give you the name of that other system. I'm embarrassed as I can't remember what it is for the moment.
Okay.
But it illustrates the point here that, as Eddie's trying to say, is we have a variety of systems. Some of those will be integrated into one, others probably not, but they're going to be critical for the Universal Healthcare Commission or whatever the body is that's going to be regulating this system.
Definitely.
So Matt,
And yeah, I think you hit it well in that that clinical data, maybe is relevant to this, maybe is relevant to another design element. I think for now, a footnote to put a pin in it to make sure that we cover it somewhere within, this body
Sure.
of documents would be fantastic.
Thank you.
Before we move on to any other sections, anything else on data collection and oversight? Fantastic. Okay. I know that there are several other pieces of the document, and perhaps maybe some of the discussion today could be centered around more of the roadmap, which is pretty new to folks. So, perhaps perhaps we can hold the floor for another minute or two to see if folks have any other potential edits to this document. Otherwise, I'd be happy to dive into the new stuff. But just gonna hold here for 1 second.
Oh, I just need to make sure I've said my piece about the reference-based, and so where's the reimbursement portion of it?
Scrolling down
Is-
here, should be under payment mechanisms, price, and payment regulation. Yes.
Yes. Yeah, I wanted to just say my piece around that. So I support that there's been that carve out for critical access hospitals and sole community hospitals. When we're talking about provider reimbursement, providers aren't necessarily always under the hospital, right? And so that's where, and then we also have rural health clinics. And I heard in the public comment, which was I loved hearing, is that think about community health centers as well. How does that impact it if we were to do something universal? When you're thinking about what I call the federal community health centers, right, is essentially a different entity. But what would that look like if we, as Washington State, were to try to take over that care? So that's where I just wanted to make sure I did send out that email to explain kind of my position, to make sure that either it's carved out, because if we are going to be doing reference-based pricing in rural, the references aren't going to be sustainable, and they're not. So we're setting ourselves on a foundation that's going to crumble. And so I wanted to make sure if we're going to do the carve out mechanism, then we need to call that explicitly out in the provider section as well. Unless what I am hearing is that the critical access hospital and sole community hospital carve out, that concept is assumed somehow. But I know in the legislation, it's just for that, which does not cover providers. In that aspect. Okay.
Yeah, and lots of thoughts on this one. Thank you for sending out your thoughts ahead of time. That's super helpful for me, and I'm sure the rest of the committee members. Let's go to Roger first, and then go from there.
Yeah. Let me again applaud Sarah for her continuing to bring this issue up. I have a question for us. We've had this discussion about rural health, et cetera, as it relates to reference-based pricing, et cetera. I guess my suggestion might be is would we have an opportunity to have, lack of better words, maybe another, your last one, Harrison, but another sort of appendix or a roadmap with a particular discussion around rural health? And it's there's long discussions we can have about reference-based pricing. We can spend time on that, but on the whole area, given the critical role that reimbursement plays. And I guess what I would like to offer is, would we have an opportunity to have a work group, volunteering Sarah and others, I'd volunteer myself, that could focus, some suggestions around how we're going to try to transition, if you will, and deal in this transitional world around rural health issues, with a focus primarily on reimbursement, but there's a couple other things that may come into play there. So is that, and let me just say again, because the other one that's kind of floating around out there that we briefly referenced, but it's a big issue, is primary care, which is separate, if you will. They're all related than rural health. And the reason I keep bringing those up, but those are two areas, and Pam, I know you've heard this also, that continue to come up in our conversations, as well as it does with the commission. So a proposal would be is that another subgroup that, we can go forward what we have, but it's saying we're working on a couple other pieces on this, several other roadmaps to try to speak to these other issues.
I see the other hands. I just want to ask a clarifying question of Roger while we're still on this. Are you thinking that would be something that would be part of this proposal we're looking at now, or something that would be part of the roadmap, or something that, we take this to the commission and we say, oh, and we're working on this rural piece that we will be adding? I'm just curious where you see this fitting in.
So here's a suggestion, and it's part of this time. And I know you want to get some of this information before the commission, so we need to continue to move forward. I guess my suggestion or proposal would be is, in that presentation, we acknowledge maybe at least two other areas that FTAC, or a work group with FTAC, would be providing some additional transitional solution ideas. And at least, one is listed general area of rural health, and the other is around primary care. I know when I say about primary care, this gets kind of conflated with the work that, Jane and OIC are going to do about the universal primary care system. So that one we may want to stay away from a little bit, but I think, but in particular, around this rural health issue. So the proposal would be is to go forward with what we have, and everybody agrees to it, to tell the commission or ask the commission, whatever we take, that we want to continue to work on rural health issues, and be a sub-work group, if they're comfortable with that will focus on those array of issues, particularly as it relates to reimbursement issues. I'm sure I'll drift a little bit, because I know Sarah will let it drift in the best sense of the word.
Certainly. Really interesting.
I mean it positively, Sarah.
A few thoughts on that, but I see we have hands, so let's go to Hiroshi first and then Pam.
Yeah, thank you. I might be jumping around topics here a little bit, but one of the things, I was looking at the roadmap and then going back and forth to the payment mechanism thing. And one of the areas that we need to address somewhere in here is, I didn't see anything on the roadmap that took us to, especially in the rural areas, to capitation. And having read some of Sarah's comments before the meeting, I think that's a really important thing, because it's my own personal belief that even though reference-based pricing can be an effective price control mechanism, it doesn't address some of the issues I think Sarah's been talking about on the rural area, which is fluctuations in volume. And how do you manage that under a payment reform system? And I think ultimately we would have to move to a capitated system in order to deal with some of those fluctuations, to give predictability to cash flow, and especially in rural areas, but I think it works for any hospital. But so I'd like to see somewhere in this document that we're going to consider that, and it's an important part of the work.
Certainly. Thanks, Hiroshi. Yeah, seeing some agreement from Sarah, and yeah, definitely, my orientation to this is all work products wise. So a few thoughts in terms of how this will affect moving things along, but I'll go to Pam first. Oh, Pam, you're still on mute. Go ahead.
But I unmuted myself, so that's
There you go.
worked. I really appreciated Sarah's memo. I think that was really helpful to see that ahead of time. And just kind of following on Roger and Hiroshi, I think we should deal with the rural issue really as robustly as we can in this document. But I was also thinking just in terms of how we work with the Universal Healthcare Commission. I think that the norm is not for us to say, here's your work on rural health that you didn't really ask for. I think we need them to ask us for it. So I think I don't think that's very hard to engineer, but I think we should think about, making a query to them about, we keep running into these rural health problems. Do you want us to do something larger? Do you want to think about how you want to handle these because they're going to be separate problems for rural every time we work on something.
Mm-hmm. Certainly. Yeah, I think that would be the appropriate framing. And so far they've jumped at our suggestions for us to do more work. So
yeah, that's true.
No reason to think that they wouldn't do that again. The only other thing I'll note here before we go to Bob is that there are different work streams within HCA that might address some of these issues, maybe even in ways that overlap with this thinking. One initiative within the Rural Health Transformation Program expresses, essentially outlines a co-design process that would get quite a ways towards a lot of what we're talking about. In the interest of moving certain things forward, I'd wonder, what our thoughts are on referencing that and keeping, work streams separate, or perhaps diving into the fray. But sounds like there's certainly a lot of appetite within the group to get into those issues further. Let's go to Bob.
Yeah, sorry, I've been distracted, so I may not be up to speed on the full discussion here. But when it comes to rural hospitals and volume-related issues, I think in general, moving to reference-based pricing or any type of fee-for-service type of payment system, and reference-based pricing is fee-for-service. You got to be worried about both sides of the volume equation. Fee-for-service stimulates excess unnecessary care and low-value care, but it also puts providers like rural hospitals at risk, because when they lose volume, they still have their fixed costs to pay, and they have no means of doing that. So this gets a little bit technical, but in Maryland, we had a fairly sophisticated and very unique adjustment for volume that worked both ways. One, it addressed the issue of fee for service, which is that under fee for service, the more volume you do, the more you get paid, the more you generate in terms of profits and surplus. And that's why fee for service stimulates excess utilization or unnecessary care. That adjustment was called the volume adjustment system. It was a form of capitation, although it wasn't as severe as capitation. You think about it as kind of partway between fee for service and full capitation. It's sort of the middle ground where hospitals are paid based on their marginal costs. And this gets, I apologize for this being technical, but the point I want to make is there's a reverse side to the volume adjustment, which is it funds hospitals' fixed costs when volumes decline. And I think that's the type of, or the spirit of maybe the comment, going to a capitated system. I wouldn't advocate going to a capitated system because that's a very extreme form of reimbursement, and it tends to build in complacency for the providers, that they get paid, their budget, and that's all they have to worry about. They don't really worry about managing care or doing so. Anyway, I would suggest, yes, this issue is real, but it has two sides. One, you want to prevent or counteract incentives for fee for service to stimulate more volume than is necessary, but you also want to support hospitals that are losing volume and cover their fixed costs. And this volume adjustment system does that. And I'm working with Vermont now in the context of their reference-based pricing structure for all commercial payers to help them build in that volume adjustment. So I just want to throw out, there's another option here, which is sort of a kinder, gentler form of capitation, but it also has that benefit of supporting hospitals that are losing volume. Sorry, that was long-winded. I apologize.
Got it. No worries, Bob. And no need to apologize for technical details in the Finance Technical Advisory Committee. It's right there in the name. But yeah, and hearing that there's some daylight between members here, and so this could be a big topic for us and occupy quite a bit of time. Let's go to Eddie, and then we'll go from there.
Yeah, I saw Bob's hand up, and I thought he was going to bring up the global budgets. I thought that was going to be a mechanism used for hospitals in addition rural health centers. And so that was, I guess if Bob can respond to that.
Bob, can you clarify there?
Well, excuse me. We set up fixed global budgets, which is like full capitation. Excuse me. In Maryland, and what I've found is in Maryland and also in Europe, where they use fixed global budgets, it caused the hospitals to start to stint on care or shift care out of the hospital to unregulated providers. But the stinting on care was particularly troublesome. It caused big increases in wait times for elective services and also emergency room services. This middle ground approach that I'm talking about can be a form of global budgets. I've termed it in the literature, the articles that I produced, as flexible global budgets. So again, I just want to put it out there that this is a form of capitation, but it's not full capitation. It's a little bit more moderated, and I think it's superior to global budgets, setting fixed global budgets for hospitals that don't vary no matter what your volume is during the course of the year. The flexible global budget does moderate. It goes up and down, but it doesn't breed in this complacency that you get in hospitals when they're fully capitated or under fixed budgets. So just I'm in favor of global budgets, but a different form of global budgets than what Maryland uses, more of a flexible global budget. And later I could do a presentation on that if people are interested.
The parts that you say flexible, are those not baked in, or are they kind of set of which items
the parameters in terms of flexibility would be set in advance, but some regulatory agency has to decide what those flexible parameters are. So if you can indulge me for just a second, the evil of fee-for-service, the bad part about fee-for-service is that it pays 100 cents on the dollar for every new service a hospital does. When the hospital to produce that service, they incur variable costs, which is more like 60 cents on the dollar. So fee-for-service rewards hospitals in excess for doing more volume. They're paid 100 cents on the dollar for a new case or new test, when their costs, their marginal or variable costs, are closer to 60 cents on the dollar. And so that excess of marginal revenue over marginal costs drops to the bottom line for all the new cases. And that is pure and simple why hospitals do a lot of unnecessary care, because they can increase their profits as a result of that. So what I'm suggesting is this volume adjustment system, which would pay on the basis of the hospital's variable costs for new volume. So you remove that excess, that windfall that they get for new volume. But this volume adjustment system has a flip side, which is it would pay a hospital's fixed costs when their volumes decline. So it would be very protective of rural hospitals that are losing patient population or deteriorating demographics. So it's a form of capitation, but it's a more responsive and I think a better type of global budget than a fixed global budget, if that makes any sense. So Eddie, I hope.
No,
that
it does. And the fixed cost component is in terms of what they report on a current claim. You're
Well,
saying the allowed amount versus the paid amount?
Well, no,
Or
so it would have to be in the context of a rate setting system, and you'd have to have the rate agency decide what are the fixed and variable costs that we're going to fund. In Maryland, we found for surveys that we did and talking to CFOs, CEOs, that hospital costs for large, medium and large hospitals were about 60% variable, 40% fixed. So you could use those parameters, or you could adjust the adjustments to be a little bit more stringent, closer to full capitation than that. But the point is, this preserves payment following the patient, which is important to do for a variety of reasons. Whereas if you just capitate, you have now truncated that flow of payments for each individual treatment of a patient. And it does build in complacency for hospitals. And then they start to stint on care because it's easier to stint on care than to actively manage care.
so it's a risk adjustment at like the MCO facility basis.
No, well, it's applied directly to hospitals, so we're not talking about MCOs at all. It would be you have a rate setting agency that sets rates, reference-based pricing. Let's say you start out with that, and then they would adjust those rates for these volume changes that would occur, where they would pay. A hospital can only earn their variable costs for volume increases, but then a hospital that lost volume would be paid their full fixed costs, so they didn't lose money if they lost volume.
Okay. Oh, thank you. I didn't take some time.
Yeah. I'm sorry, this is complicated, but I can tell you my experience. I had a lot. I created the fixed budgets in Maryland. Now I regret it because the hospitals stint on care, and then they don't care anymore about length of stay because all they care about is cutting volume. And they do it however the easiest way to cut volume, and mostly it's stinting on care, and that's not a health system that we want.
Yeah.
Thanks for the clarifications, Bob. A lot there. Let's go to Sarah.
Thank you, Bob, for that explanation. Because I was going to say the Maryland model doesn't. It looks like the only rural facility there closed a decade ago after global budget systems were implemented, right? And so I would be probably looking more at what I had kind of talked about around capacity, and there's that idea that's been around from some other people other than you about standby capacity payment. And I guess I'm leery
Harold Miller.
And I know that I think Roger had worked with Harold with the RAP. And also I heard Pam, this isn't the first go around with trying to solve these problems. Right. And so, I'm leery of the global budgets for rural. And again, I don't know who has actually tried to implement a sustainable
Maryland, but I think you're right.
Within rural specifically, and then scaling it from rural, Bob, up to urban. So this would be my drum I'm going to beat, is that why are we doing these carve outs? And I already said that at the beginning of my initiation here, and no apologies because I am appointed and this is what you get.
Yeah, when you say carve outs, I'm sorry, Sarah, what do you mean by carve outs? Sorry.
So my concern initially is that if we're going to do a universal system, which is what we hear public commenters say, is that we were concerned about carving things out because we want it to be universal, right? Because when you start carving things out, all of a sudden it's not universal. Right. And so all I wanted to say is that we do have an option to start in rural settings and make it sustainable there and scale it up. And through Harold Miller's standby capacity payment process, that helps make sure there's access to services without incentivizing facilities to not do services. And so that's all I wanted to say. And I won't take up more time because, again, I could go down this rabbit hole.
Yeah, that's all right. I don't mean to prolong this technical discussion, but I agree with Harold. But the volume adjustment for hospitals, like small rural hospitals, are at risk for losing volume. does support their fixed costs, and the standby costs are fixed costs in essence. So it's maybe more of a formulaic way of doing what Harold Miller is advocating. It does support rural hospitals, and your point too. Part of the reason why the one critical access like hospital in Maryland went out of business, actually, I think there was another one, is that the fixed budgets just transfer a ton of financial risk to small hospitals, and their patient population, the morbidity of their patient population fluctuates a lot from year to year. And being under like a fixed payment, it will put their lights out if all of a sudden you get some sort of influenza epidemic or problems in the rural areas. It will just put their lights out financially. And so this volume adjustment is a more kinder, gentler approach, but it does cover their standby costs if volumes were to decline. So that's another reason why I like it over the fixed budgets, which I think are bad because it will cause hospitals to stint on care, but it also transfers too much risk, particularly to the small hospitals.
Great. Hearing some, hearty disagreement and some agreement as well here. And I think that this conversation can go quite a bit. I want to keep us a little bit on track. Let's go in order of hands, and let's get through the hands for now, and we can go from there. So clarification time paused for now, and let's go to Roger.
Yeah, thank you. Just another comment back to one that Eddie said. When we're talking about rural healthcare, our focus via Bob has been on hospitals, but as we all know, two critical other aspects, and I'm going to use Medicare structure on this one, are rural health centers and FQHCs that are a critical component for rural health. So when we're having discussions about rural health, as my thinking of, yes, we got critical access hospitals, sole community hospitals. We actually have a new model out, Sarah, you're aware of the rural emergency hospitals, a model that's coming forward that deserves some conversation. So one comment. Second comment would be is, Harrison, while I appreciate what I think the rural transformation monies are going to be dealt with, I don't think they're going to be dealing with the issues we're talking about. When I read all that stuff, it is not about sustaining rural delivery systems. So, I think if you watch, if you look more carefully at what they're laying out, that what's required in these grants, if we focus a bit of our own time on this subject matter, I don't think we'll be duplicating or compromising their work. Just because I think they're going down, as I understand, a separate track. So my proposal again would be: this is a great conversation. Suggestion would be and it's back to what Pam was suggesting. Somehow, if we could bring forward to the commission when these documents go forward, that we've had some spirited conversations, good conversations about rural health. And there's some way of saying is that there's maybe, put words in our mouth, some interest in trying to pursue that further on behalf of the commission, focusing on reimbursement, et cetera, aspects, as another piece to this that would be added into the eventual document, right? So
sure.
Am I making sense on
sure.
that one? And Pam, I'm sure can do a
sense.
good job of planting that seed for us if we so want.
Sure. Yes. Hear you loud and clear, and I think that is kind of what we're coalescing around. Let's go to Hiroshi.
Yeah, my comments really quick. Thanks. I would just suggest that we take up Bob on his offer to do the presentation on what he's doing in Vermont related to some sort of a variable global capitation approach, because I think it would be really instructive to us and some of the variables we need to be paying attention to.
Got it. Yes, always up for more presentations. Mary.
Yeah, thank you. I think I'm echoing a bit what you said a moment ago, Harrison, and also Roger, also keeping an eye on the agenda and on the clock, thinking that maybe, I don't know, Harrison, if you want to also go through the roadmap today, but while we are looking at the design proposal document, was wondering if we need a formal vote from FTAC to approve this. I just want to point out that the text we're looking at now talks about traditionally under-resourced services and settings, and it calls out primary care, behavioral health, rural and underserved. So it does touch upon it. And so what you were saying, Roger, would it make sense to take this to the commission? We point out, yeah, we're calling this stuff out because we know that these can be different cases and that this, could be carve out. And Pam's question, do you want us to take a closer look at rural? Don't know how we move. I don't know if we need that formally, Pam. I'll send that back to you.
Yeah, I don't know. But I do think, in terms of the decision making, they're the deciders, and we're supposed to be helping them make their decisions.
Certainly. So it seems like, one question is, would you like us to dive deeper into rural aspects of provider reimbursement and also other design elements as well, and perhaps primary care is in there as well. And then, another question that perhaps is more logistical is, is that folded into appendices to these documents, or does that live, perhaps almost entirely separately as a work stream that moves along in parallel with these others?
Yeah.
And Sarah's hand is up.
Yeah, can you scroll up on that document a little bit, because I see that we're calling that out.
Do you see it? Do you want me to?
I meant, I guess scroll down, I suppose, so I can read. So, come back up.
It's
so that we can. Yep, the payment mechanism. And then you go down, and we're suggesting that it's going to be solved by RBPs, so reference-based pricing. And I think that's the debate that's happening with us, right? So I would not want that language to go forward, in my opinion, because I don't want to infer that that would be a solution when I think we're questioning. I'm questioning that.
Could you clarify what are you objecting to exactly? You're against reference-based pricing?
No, I'm just saying that. So, and I wrote a little thing because I want to make sure I get it right. My understanding is so that we're having this, so like the standard fee for service system and the global cost caps are calibrated to the lower average cost of high volume urban hospitals. So like as the small hospital, we're going to have those fixed costs, and I bring up the standby capacity. So, and I give an example in my little notes here for myself. So my concern about cost containment models like reference-based pricing. So if there could be a caveat within the reference-based pricing that there would need to be something special for rural there versus
I mean, like the volume adjustment that I'm talking about that pays for the fixed
potentially what you're presenting, but I want to understand that more.
Sure. Right.
And then but since I hear that we want to be able to present something to the Universal Commission, that would just be my caveat in that area. If we could put that there were.
Yeah, I think I'm in the wrong part of the document. Harrison, do you know?
It's hard to keep
where
track.
I should be?
No, I think we are roughly in the right place. This is where we're talking about, distortions in the fee schedule and the need to correct that. And I think broadly, we all probably agree on that. I think that there might be certain important caveats and considerations for rural communities and rural facilities that that Sarah's flagging that, might need to be considered on top of that. So I think that, the suggestion here is perhaps to drop a footnote, a note for us later, to perhaps move this more general document forward and consider, folding some of this more hearty debate around what to do with rural facilities, potentially into the roadmap, or depending on the commission's decision, into another document. But let's go to Pam.
Yeah, I'm just adding to what you were saying, which is I think there might be a number of ways to deal with rural facilities when it comes to reference-based pricing. I think that because you can set a ceiling, but you can also set a floor that is different for the rural hospitals. So I think that footnote you're going to write, that sounds really good to me, should include the fact that there probably are more methods than we really had time to get into and discuss and analyze, but that there should be this methodology applied to rural hospitals.
Certainly.
So Pam, sorry, I apologize. What method you think the reference-based pricing should be applied, or some other exclusion?
No, I think that I just broadly reference-based pricing across the system,
Right.
but that you have to look at rural hospitals. You have to mitigate the impact of reference-based pricing on those communities, and that there's more than one way to do that. Is what I'm suggesting.
Sure.
Yeah.
Well, but I just, again, you have to trust me on it. But I'd be happy to do a presentation. My volume adjustment idea does that. It helps. It funds their fixed costs, their standby costs, whatever their fixed costs are, and their fixed costs are probably going to be quite high relative to a large hospital, for the full-time staffing, and they just have a higher proportion of bricks and mortar. So their rural hospitals' fixed costs are more like 80% fixed, relative to a big hospital, which has more like a 40% fixed cost proportion. But anyway, so yeah, I agree with you. But I think the volume adjustment would do what you are suggesting, and what Sarah is suggesting. It would support the rural hospitals and their standby costs.
Okay.
And just a clarification here, dealing with those intricacies, in the roadmap document or something separate that speaks specifically to rural, I think would fit the sort of shape of these documents currently, and that this one is sort of general, high level, and gets the bulk of our thinking, minus some, pathway specific considerations.
Yeah, I wanted to respond to Sarah's comment. That reference in this document, this principles document, not principles, I'm sorry, this document we're looking at, the inclusion of things like rural hospitals, underserved areas, etc., behavioral health, primary care. That language, because I helped kind of be sure what got in there, was not specifically necessarily related to reference-based pricing. It was a thematic area that we, when we're talking about reimbursement, needed to address, not necessarily through reference-based pricing. It's maybe unfortunate that it looks like that's the case, but that wasn't the intent of that piece, number one. And number two, I'm going to kind of go back to, and we'll beat this one to death. Bob, I'm with you on these other strategies, but I'm going to go back to a point that Pam made. We're today operating in a world of reference-based pricing. The things that you are strongly advocating for are steps down the road. And my point back is, with reference-based pricing, specifically what they're doing for 7PEB, can incorporate other strategies in that model today that would be able to enhance reimbursement for, let's say, rural health providers. We talk about it in more detail. My point being is, these are things that we can do now. And I'm going back and kind of arguing for not only a separate section, if we can get the support from the commission to look at rural healthcare issues, because global budgeting for hospitals is not going to take care of all the issues in rural health and reimbursement, by no means at all. And you know that.
Yeah.
So I keep coming back to that theme.
Just briefly, I see some hands. We have 3 minutes left in this section. We've had a wonderful discussion. Let's go to Sarah, and then I'd like to try to wrap us up here.
On the page right now, that top paragraph, the sentence that says the state could consider using RBP to correct these distortions. That's what I'm talking about. I get that that is literally saying that. So that's all I wanted to make sure, maybe a little footnote that says whatever needs to be said there, to make sure that isn't confused when it's presented as though that's the end all be all, or whatever their interpretation of that is, without us having the understanding of our concerns.
So my proposal is that I would work, Sarah, with you and whoever else wants to, on this footnote that will flag our concerns, and that, right, we can discuss the possibility of a rural specific document with the commission, and that may have impacts on what the roadmap looks like, but this sort of strategy will get this document in front of the commission, help us move along, and remember, financing is waiting in the wings, so we've got a lot of work ahead of us, but these are really critical issues that we're hammering out, so appreciate everyone taking the time. With that noted, so I think we have a footnote up here, a
Yeah,
footnote down in the data section.
Yeah, the footnote also about data sources
Correct.
that we discussed earlier. Okay, just want to make sure that was noted.
Those are two edits that I will ensure to draft with the relevant folks and circulate to members of this committee. With those noted, are we comfortable moving for a vote on just these proposals? Proposal singular, excuse me.
So Harris, make a proposal. This is going to be a work in progress. I think to get this document before the commission and whatever form we do is advisable, because I think it'll give them a clearer sense of the work that we have been doing. I mean, the principles are great, but they're abstractions, right? This is trying to flush that out a bit. And if nothing else, it will give to the commission a sense, and maybe with these other two roadmaps of what we've been working on. And the point is, are we on point at all for the work that they're looking from us for? And hopefully it is, but if not, then we need to go back and reiterate. But I concur with you and Mary to get it forward, and at least in this draft form, to have a chance to see it.
Got it.
So
And yeah, they received
kind
the
of a rough-
proposal, with the concerns about rural health noted.
Sure.
Other than that, fairly positive feedback. They have not seen the roadmap yet, so good point there, that they really haven't seen the full body of work. So, not hearing a motion for a vote. I see Sarah, you're off mute. Feel free to. Oh.
Well, I was just gonna say, I was gonna second Roger's motion to do whatever he just said.
I think to send these back up to the commission for their feedback, but not necessarily endorse the proposal with FTAC's support quite yet.
I kind of think that's, and we talk about, I heard the Universal Commission talk about having that iterative process and being able to allow it to go back and forth. And I think it's wise for them to understand that this is the reality of how we're going to get this done. Mm-hmm. and seeing if we're on the right track, and can we dive deeper into these concerns, or are they fine? Maybe they're fine with this, and then we can move on to the next level. So that would be, if it's appropriate, that would be my second. But if that's not, then I'll give you guys back the floor on how to appropriately do that.
A fantastic second.
Yeah, I'm not hearing any concerns about moving it forward.
Yeah, so that sounds like what we'll do. Thank you everyone for your feedback on this, especially to the work group members. There's been a lot of hard work on this, making more and more work for ourselves, but really giving the commission a lot of things to work with. So thank you all for being so involved in this. With that, I will hand the reins back over to Pam. I think we're going on a break, a well-earned break.
Yeah, so we have 10 minutes, so be back at 3:45. Is that right, Mary?
Sure, that works. What do we have? 3:45, 3:47?
Yeah,
do we want to take our full 10 minutes?
Yes, okay, you get your full 10 minutes, 3:47. I'll see you back then. Thank you.
All right, thanks everybody.
Great conversation.
Hi, Mary.
Hey there, Roger. How are you?
How you doing?
Good.
You know, uh, on this question, I'm sorry we're taking too much time today, but I feel like we're in a situation where we're under a certain time schedule, which is, of course, the advocacy community always says we want it today and needed it yesterday, which I always agree with. But on some of these issues, saying, and again, I'm gonna use this thing on rural health just as an example, saying, if these are important things, and again, it's up to the commission that, if we have to kind of back up or do some work groups, sub work groups on these various aspects, hopefully that's, that can be made to work. Because I feel like,
so.
okay.
I like
think
Roger, the idea on, the current status quo, the transitional solutions we've talked about, and then the new transitional solutions, and they all present different cost profiles completely.
Yeah, yeah. Well, I'll use one example. I don't mean to take our time, but off of the resource-based, reference-based pricing, excuse me, get my terms here. There, as Pam illustrated, this is things that we can in theory kind of do today. You could adjust that system. For example, what they did for SebPeb, they created a floor, right? 150% for primary care and behavioral health. Well, without getting all the detail, you can do that for example, critical access hospitals. You can do this for a variety of things. My point being is, we're talking about this continuum of how we can implement things. Some of these deals, in theory, practice, we could do relatively sooner than, for example, the longer pathway that Bob has been laying out. So I guess I'm trying to concur with you that there's, part of our mandate is doing things we can do incrementally, right? So I don't see these conversations being inconsistent with that mandate. Pam, do you?
Well, I'm actually looking at the clock, Roger. So
Oh, sorry. Sorry.
I think I do. I mean, it's interesting conversation. I think that to stay on time, we should probably welcome everybody back and move on to our next topic, and bookmark that comment for next time. So welcome back, and then we have one more topic, and it's not a small one. It's on discussing the OIC proviso, and Jen Scott is going to lead us through that conversation.
Thanks, Pam.
Yeah, thank you.
Next slide. This is just a reminder of the background on the OIC proviso, $250,000. I think just important to highlight the deadline is that we do need to spend the money by the end of June next year, so that's coming up, and that it provides guidance for making a recommendation versus being the recommendation itself. Next slide, please. So the commission has discussed the proviso a couple of times in recent meetings, and they've identified the elements that they would like to focus on, which are financing and or provider reimbursement. And at the last meeting, ideally, they suggested that they would like the analysis to provide insights into financing for both universal primary care and the universal healthcare system. So at the highest level, the questions that are here, the commission is really asking how much would this cost and how will it be paid for? And also asking if we can look at an analysis that will show how universal primary care cost compares to the full universal system. So the goal of today's discussion is to come up with several, maybe 2 or 3 recommendations that FTAC would like to suggest to the Commission at their June meeting related to financing both UPC and a full universal system. So kind of taking these high-level questions and scoping them down a level deeper so that the Commission can get a better understanding about how an analysis might answer these questions. And then at future meetings, we'll have more time in this group to flesh out more of the detailed questions as we prepare to work with the consultants. Next slide, please. So there are a few questions here. So actually, can we go back one slide? Yeah. So a couple of questions here. Just trying to make sure we scope the question so that it can actually be completed within the budget and the time frame. And then just wanted to ask the group, do these feel like the right big areas for consideration? Is there anything that that you all think needs to be added for consideration at this point? Roger?
Yeah, I don't know how to approach this other than just saying it. You know, some of these questions say, well, you know, we need to look at options of, you know, pricing out the universal healthcare system or the universal primary care system. Or finance, was it financing those? I believe it was that theme. Excuse me. In my opinion, we can't begin to get around the issue of financing options until we have some parameters about what these systems are going to cost. And so the best that I could think of at times around some of this issue around, you know, financing, given that we do not have cost parameters or estimates for, you know, the system we're still trying to design and the universal primary care system that, you know, Jane's going to be working on. I think it's not possible. The best we could do on the financing side, in my opinion, would be to work on laying out a series of lack of better words, revenue options or financing options. And I continue to kind of come back to this notion of saying, you know, the state has a variety of areas that it's drawing financing from, you know, for the general fund state. I mean, there's a litany of this stuff that could be used to help finance this deal, as well as, you know, other additional financing options. For an example, we often talked about a, you know, a payroll tax, right? That's to deal with ERISA. My point, Jennifer, on those are that I think the best that we could offer at this point in time is to try to get a detailed inventory of what those are today, and, you know, maybe some additional options. And at least with those, the inventory of those that are today, what we're collecting on those various ones. I'll give you a specific example. We have a premium tax, 2% premium tax on carriers. Money goes into a pot and it goes to a variety of funding sources, right? Today and as far as probably sitting there in a reserve. Well, that would be an example. Say, well, that's something we have today, 2% premium tax. Here it is. Here's what's collecting. You know, somebody knows that. And that could be when we're looking at potential financing options for the future. Once we know what these things are going to cost, we can say, well, that's one avenue you could look to. We could increase the premium tax from 2% to 3% or whatever. I don't mean to trivialize it, but given that we don't know what we're financing, I think laying out those series of existing revenue options, and some others that we could come up with would be useful, or having the consultants do would be useful for the commission. It's going to kind of give them, if you will, a menu upon which for them to begin, you know, thinking about financing deliberations, and for ourselves too. So
I think that's on a future slide, isn't it? A few slides ahead. One of
okay. Sorry, I
yes.
mean to get ahead there. Excuse me.
No, it's okay. What's the next one?
I do think
yeah,
that the commission wants to know about costs. So I think maybe, you know, maybe it was just a misnomer we had to categorize it as an element, but I think that, and correct me if I'm wrong, Mary, that they are definitely interested in knowing how much both of these systems would cost, as well as how we would pay for them.
Yeah, I think that's.
Well, let me play the devil's advocate again. I keep doing this. how the hell can we do that until we know what the system is?
Well, that's the good feedback because we are trying to figure out how to scope this question. And if I can, I'm going to try to paraphrase what I think I heard from the commission. Maybe other people heard different things. I heard them saying that they are very interested in, basically what does this cost and where does the money come from? I'm just really oversimplifying that. And as Pam noted in her report out earlier, it's up to the commission to decide whether to pursue universal primary care as an interim solution. That's still an open question. And I think ideally what they would like to see is let's come up with an idea, or let's come up with a proposal, or let's scope something that would apply to the eventual universal system. And ideally, something that also could be maybe modified is the wrong word, but somehow we could also incorporate this universal primary care idea so that we can hit both marks with the same question. As the Italians say, feed two birds with one fava bean. I don't know if other people heard the same out of the commission. I know Jane is here, but that was my takeaway.
Let's see, we have a couple of hands. Hiroshi.
Yeah, thanks. In terms of scope, one thing that we probably should add before we try to jump into figuring out how much this stuff costs is what definition of primary care are we talking about?
Right.
Right. My guess is that we're not talking about the current system. And there are other different models for, team-based primary care and such, and that we need to at least come up with a proxy and agree on what that is before we start doing a lot of economic work.
Matthew, I know you have your hand up. I'm just going to see if Jane wants to respond to the question about primary care quickly before we move on to you.
Thanks, Jen. So Hiroshi, there's a couple of ways to treat that. There's a statutory goal of a 12% spend on primary care in Washington state. And what 12% would give us is the ability to really design a robust primary care delivery model. And if what the commission is asking for is modeling around cost, what if rather than saying first we have to define with great specificity what the primary care model is going to look like, instead, because we're talking about cost, you built in assumptions about transitioning, let's say, over a 3-year period to 12% spend on primary care. And then because it's really all about if the commission is interested in looking at cost. I agree, Raj, all the questions are not answered, but the really big question is what assumptions would you make around trying to cost something out, knowing that there haven't been decisions made that would provide great specificity on exactly what the system is going to look like. What if your assumptions are the recommendations that the group just came up with around consolidated purchasing, reference-based pricing, with help for rurals, and moving more to a competitive contracting model? What if those were the assumptions, and assuming the benefit package that's already been discussed, assuming the eligibility that's already been discussed? And it's not, you're not, I mean, the other thing is, right, we have $250,000. We don't have $750,000. So what about something like that?
Matthew?
Thank you. I would just like to point out that where the most expertise in the state regarding the budget and what tax can raise what are all public government employees. And we are talking about spending $250,000 on a private contract. We have the expertise within the state government to answer those questions. The $250,000 needs to be spent on something that is difficult to figure out for the industry, where we are not the expertise. And so I would consider it a waste of money as someone from the Department of Revenue to spend $250,000 on a contract for them to call me and for me to give over the information about how much these items would cost. In fact, I'd probably resign and pick up the contract myself. Let's spend the $250,000 on some industry specific question about dynamics and incentives and things that we don't know about. The state knows plenty about raising money and how much the premium tax, if we raise the premium tax from 2 to 5%, we can figure that out in a day. Anyways, I hope I didn't say that too strongly, but that's how I feel about that $250,000, is spend it on something that we don't know. And that's something that's hard to figure out, and that we need someone with real expertise that will be a key to answering some of the policy questions about incentives and making the system work.
Thanks, Matthew. Sarah?
Yeah, I think you might have popped my bubble there, because I was thinking about Peb and Seb and wanting to take maybe Milliman's report and extrapolate out of that the primary care that has been done, and then maybe to is it Jane? I apologize. Her suggestion to see what it looks like to phase into that with the work Milliman had already done. But it sounds like you would resign, and that's not a good idea. So then my other thought would be, how do we take, so in the Universal Healthcare Commission, what I heard was there was concern around trying to do anything around primary care because we don't want that to be a waste of time. But I heard it as, we need to start somewhere. Let's try to use that funding to figure out how we could universally do primary care in the state with whatever data sources we needed to do that, and present what that would look like with that idea to get spending up to that 12%, if that makes sense, as a proof of concept for a phased in universal approach. So that would get your twofer, where we put within whatever we can with that amount of money, answer whatever question that's foundational in the primary care space, and then scale it up into the rest of the system. So thank you.
Pam?
Yeah, so I appreciated the comments about let's not ask questions. We can find the answers out to ourselves. That was great. One of the things that just gets me puzzled is some of these things, they change what we're trying to measure. So if you do universal primary care, it changes what a universal system would cost and what it would look like. And if you don't do it, then it's a different kind of set of costs. The same is true like doing reference-based pricing or global budgeting. Those things change the overall trajectory of what the system costs. So when the commission says we'll figure out both things, well, you kind of almost have to make up your mind what system you want to build and what it looks like. One of the things we could do, there's a hypothesis that if you did a universal primary care system, that it would save money. And if you go up to 12%, are you truly pulling costs out of the more expensive parts of the system so that you have overall, a more manageable cost curve? I think that has been measured kind of in a real academic way. I don't know that anyone's ever looked at it here within our system. So, that's one idea of how we could approach both issues, if I'm making any sense.
Yeah, I think you are. The one thing that I thought we were talking about universal primary care was that it was kind of low margin and they wanted to increase the utilization of it. And that was kind of separate from the financing part, more coming up with methods to augment its current reimbursement structure. I don't know if it's going to grow the amount of CPT codes that are included in the definition of, I'm not sure. And how you get to that 12%. Is that based on our incentivizing primary care, or is that based on the traditional definition as of today?
Mm-hmm. Jane?
Say me, Jen?
Yes.
So spending is two elements, right? Spending is utilization and price. And so to get to 12%, if you're talking about a broader concept of primary care, i.e. integrated behavioral health, you're going to increase behavioral health utilization, probably, likely. But that's also, like, if you look at Senate Bill 5083, that expressly says we're going to pay more for each primary care service that's delivered, I would think it would be a combination of both. And the other thing that you're hoping in a true primary care system model is that, and Hiroshi always talks about this, that you have that the primary care docs aren't just going to say, okay, I don't have time for this person, I'm going to refer him to a cardiologist, I'm going to refer him to a gastroenterologist. You're actually incentivized to take care of somebody and use the full scope of your primary care training. So I think it could easily be a combination of both utilization and price.
Roger?
Yeah, I was just going to say that when I look, Jane, you saw this too, in the Healthcare Cost Transparency Board. I mean, their first things, what can we do, in the short run? They were increasing primary care. That's a compensation, right? It's kind of, it's one of the basic building blocks. And the course around that one is where you're going to get the money. And there were strategies around that, but my point back to Eddie, it is an assumption is that you are going to increase unit price, in this case, unit payments, as one of the first and initial steps in that process. Jane, can I ask you a question? Because it helps my own thinking of this. What do you envision for the work that you're going to be involved with in the development of this universal primary care? And the reason I'm asking about it is, you hear from people like Roger saying, well, how the heck we know how to finance the thing until we know what it is, right? And my sense would be, as part of, correct me if I'm wrong, and this part of your work, or I believe, is to develop that model. And it's more than just the folks up in UW, right? It's to say, here's what this system would look like, leaving aside how we finance it, right? You got to start there. And then you can kind of come back and say, well, okay, so how can we finance it? But we know the target we're trying to get the revenue to finance it with.
So Raj, first thing, so a couple of things. First, OIC doesn't have another $250,000 laying around to do a parallel study.
Mm-hmm.
So that's one thing to think about. And I'm with Bob, right? There's a discussion about what would it cost, and there's a discussion about how would you finance it. And given the number of hours that we at OIC spent this session working on requests from legislators around how much revenue could you raise if you do X, Y, or Z with insurance, we already know the answer to those questions. We ran about 10 different scenarios this past session in response to pieces of legislation. And you're right that, we're hoping that over the course of the next several months, and Ingrid already after me when I leave in June, that we're going to be putting more meat on the bones of what the proposal would look at. But I think when you're talking about costing out, what a universal primary care model would look like, the legislature's already put their stake in the ground about how much they want to spend for primary care. They want it to be 12% of expenditures, and we already know that we're only at 4.7%.
All right.
And so you're right, the question is 12% of what? And if you do other things to suppress overall expenditures, then the 12% number changes. But as a starting point for purposes of this analysis, you make a reasonable assumption about what total healthcare expenditures are going to be a couple of years out, and you build off of that. And the good thing is we have all the expenditure data from the Healthcare Cost Transparency Board.
So it's done, right?
Well,
take those numbers and trend them, and there it is, right? That's what you're saying.
Well, but I think to Pam's point, test the hypothesis. If you're spending 12% on primary care, what impact would it have on spending in the balance of the system? We've all had discussions about if you have a robust primary care model, all of the literature tells us that you're going to have reduced ED utilization, we're going to have reduced inpatient utilization, you're going to have better management of chronic illness. There's good evidence out there to that effect. And so, as always, Pam comes up with the exactly right thing that I should have thought of 2 weeks ago, right? Is this concept of the hypothesis of if we meet the legislature's goal of spending on primary care, what does that mean about how much you're going to spend and what it's going to take to finance a universal healthcare system? So just some thoughts.
Hiroshi?
Yeah, and this is sort of, it's riffing off of what Pam was saying. I agree, and also that it makes sense to me that the analysis is what happens if you do 12%. Because I think what then it starts scoping the answers around how much is going to be generated by quote savings out of the current system, and how much of it needs to be augmented by some other form of financing, whether it's some sort of a tax thing or anything else, right? The money coming from the state, the taxpayer, or whatever. Because I think that's the biggest question a lot of times when people look at, well, we know we need to do better job in primary care, but if we do that, are we just going to add cost to the system and then make it harder to reach what we think is some level of quote affordability for the people in the state of Washington? So that analysis that ties increased spending with a new model of care, with an assumed new model of care, and are we going to generate savings to help finance the system? It won't be 100%, but I think because otherwise I think we get into this political question about, well, gee, if we do that, all we're going to do is make healthcare more expensive, right? And then it becomes something impossible to find, to do.
Matthew?
I think that actually would be a great subject for a study is what is the cost of getting to 12% of primary care. That to me is a good use of the money that would involve an industry analysis and all that, and what part of it would need to be made up by general tax revenue. Where I would stop short is trying to identify the specific area of tax revenue, because then that suddenly becomes the headline of what it is. And the point is to stay on message. The raising general tax revenue is a political question that we should stay away from. And we should focus on these technical aspects of designing the system. So a study of how much money would a primary care system or universal primary care, how much would it save, and how much extra money would it need to become viable? I think it's a terrific use of the money, but let's not get into where would the money come from, because then we're just shooting ourselves in the foot.
So does anyone have any thoughts about how we would, is there a way to take that analysis and be able to extend it to universal healthcare more globally?
No, there's not.
Raj, why do you say no? Because what if you did something like that and then you extend it out and you were testing, okay, we know how much the rest of the system, like we think we know how much the rest of the system is going to cost. So what would happen if you applied reference-based pricing? What would happen if you made assumptions around much more aggressive competitive procurement for state purchased healthcare? Would that not be doable?
Well, let me just try it this way. If you want to say, in my opinion, you want to say, we're interested in doing, let's say, global budgeting. Let's just pick that one. You know, we talked about that one. To get estimates around that, I keep, and now we're talking about the system in the future, right? Not today. We got to know what that baseline looks like. And I'm just picking on hospital pieces of that component, right? And they're going to grow at X% for so many people. We're going to introduce then global budgeting, a series of assumptions, and it will maybe dampen it. But you're driving that all off of a set of assumptions of what baseline looks like. And we don't know what baseline looks like because we don't know the system we're going to build to. I keep coming back to that. So, I mean, the point would be, I mean, I guess the other direction is to say, well, could you go through this exercise of saying, well, let's, you know, which was your point, saying, what are we spending today? And you get that from, the work that's out there, right? That Healthcare Cost Transparency Board has done, right? You got some sense of total spend. And then I guess the question you're going to say, well, we want to increase that. I don't know where the magic number 12% comes from. So that's kind of a, do you know that number, Jane, just as a sidebar?
Yeah, it comes from Senate Bill 5399, which was passed back in 2021.
Do you know where that came from? I mean, my main point being is what happens? I'm just trying to your deal. You're saying we want to design a model for primary care, right? This universal primary care. We say, well, all right, we got to cost that puppy out, right? I keep coming back to that. And then you can say, well, we assume some savings around all that. And then we have really what our target would be. Rather than just saying, just moving to a 12% target that I guess in my mind doesn't really have much meaning. Am I making sense at all? Unless somebody said we're going to do 12% because we have a model in mind and we got to get to that model. So we're going to have to move the system that direction with increased compensation, right, for primary care. We got to expand the capacity. We don't even have enough primary care providers. So we got to get more of that in the system, right? And particularly in behavioral health side. And I'm sorry.
No, we understand.
But so I guess one point we say is, well, we would say is if we build an ideal model, cost that out, right? We can just kind of do that. I mean, through this consultant stuff. And then I'm just kind of making that how much is going into the system today, right? Medicaid, I don't know, we're going to try to grab Medicare. Are they in? You hear what I'm trying to get at here. Because I'm sorry.
Yeah, I mean, I don't know if Bob's still on, but as it'd be interesting to hear an economist's perspective.
Well,
Yeah, I'm sorry. I just sort of zoned out on part of that. So, is perspective on what issue specifically? The one that Roger's raising, or and if you could repeat it.
Raj, do you want to repeat?
well, I've been saying James raised some issues about. Let me try mine. I'll go back to my basics. It's on the issue of trying to cost out a system. We need to know a baseline we're working from. And in the universal one, we don't have that baseline in that piece because we don't have the system designed. Another approach, I guess, is to say, which, and I'm sorry, I'm really wanting to hear more than I should, would be, is to say, well, Bob, you're a strong advocate, and we're talking about global budgeting, right? Hospital global budgeting.
Yeah, the particular form of it, but yeah.
Okay, well, I mean, that's right. Variable rate global budgeting. And the question would be is, well, what's that going to do for us? And I would say, well, we need a baseline to work from to develop those estimates and assumptions. And I fear in a lot of this, we don't have the baseline to work from.
Well, I mean, if you're just talking about hospital expenditures, you do have the baseline. I mean, there are many sources out there. There's the national spending accounts. They do it by state. You can look at that. In fact, I think I presented.
Right. I've done that too. Yeah,
but that shows it by payer too. The national spending accounts, we break it down by Medicare, Medicaid, and commercial.
Yeah.
So you could say, all right, we're spending whatever it is in Washington, $24 billion a year. And you could look at what commercial is, let's say 35, 40%, 35%. So from those data, you could figure out basically where you are at this stage, or at least, within the recent past, on a rough basis. So it's possible to quantify kind of where we are in terms of expenditures, if that's what your point is.
Well, I just go another step. Actually, from our all-payer claims database, we have better estimates than what the CMS Office of the Actuary does. So I mean, there's data out there to do some of this.
Yeah. Again, I don't know how complete your APCD is, and I've heard conflicting accounts. Like you've got two APCDs, and they seem to be competing APCDs, and some have the self-funded and some don't. So I'm not sure how complete your data set is to be able to do that. But you can get a baseline just with a fair amount of accuracy by using the national spending accounts, and maybe supplement it by using some of your own state data.
Yeah.
So I think you can get to a number about where you are now in terms of private expenditures or all payer expenditures. What do you want to do? But the thing to focus in on is what you can legislate, and you can legislate caps on private commercial self-funded spending. You can't legislate caps on Medicare because they won't give you a waiver yet.
That they won't.
I'm seeing we have 5 minutes left in the meeting. Pam and Mary, do you have thoughts? Do you want to continue this discussion, or are we ending in 5 minutes?
I don't know that we'll be able to come to a conclusion in 5 minutes, but Jennifer, where do you feel we are?
And I think that the idea of kind of modeling the 12% sounds like it's a promising idea. I think the question about whether that can meet the goal of being able to kind of double dip with universal healthcare is a question that maybe we still need to talk about a little bit more, and also think through. I think how would we cost out the model, and how much do we need that to do the 12% analysis. So to me, those seem like the kind of the main questions to think through a little bit further, and wondering if staff could capture those ideas and then I don't know if it's possible to do an email dialogue or if we would need to bring it back for discussion at the meeting.
Are they expecting an answer to this for their June meeting?
We did talk about it. I don't know if they're expecting
Yeah, we did
it.
talk about it. I think I don't remember verbatim what we said. Thank you.
One of the things is time passes quickly. So we have a
Yeah.
time, it's amazing how fast it can go when you're trying to do this. But I think I have a couple observations. One is I feel that they're looking for an answer that will make everybody happy. And I don't think that's there. I don't think it's possible to come up with a question that makes everyone who wants this money spent wisely feeling like their thing they're curious about or concerned about is going to get answered. It's not enough money. And I really appreciate the comment that we don't want to ask questions to which we have the data sets to answer. So we want to go into something. And my own personal feeling would be I'd rather pick a good question and that will be useful to us and get the answer rather than expecting we can do all things, that we need answers to for this, huge project.
As I've been listening, I've been thinking, okay, so this hypothesis, we get to our 12% primary care, what do other things cost? Are there ways that could inform the universal system? It seems that could be information that could help inform those decisions as well. I mean, testing the hypothesis seems that it would have value for that. Unless I'm just misinterpreting. Okay, Christine, bail me out because I'm kind of babbling.
And we haven't heard from Christine yet.
No,
So here we
I
go.
mean, I think this would help you to understand whether or not you could get those savings, right? I mean, I think it's an important question whether you're going to be able to recoup enough savings from that 12% to offset the cost, because it sounds like it might just increase costs. Right now you're spending 12% and you're going to continue to spend. But that would be really helpful because I think the single payer, it'll be helpful in the cost modeling down the road for understanding the full effect of universal coverage or a single payer if you know the answers to that question. But I do think to get the right answer, you have to really think hard about what primary care means, because to get to 12%, if you're only spending 4.4%, does that mean that now people start billing other services as primary care or something like that? I'm just not sure what is included in that 12%. Or even, as somebody said before, what's the denominator for the 12%? So those are all important things to know.
Hiroshi?
Yeah, thanks. Yeah, I think now I won't talk too long, but I think that was a nice description of how the connection between the primary care initiative and universal health care coverage could be from a cost perspective, right? Because in any way, there's no point in doing this unless we make the system better. I agree that with Bob, that the baseline is what we're spending now, and we're trying to make that better, right? And so if we make the assumption that we have the 12% and some assumption of what that scope of service looks like, right? Then, and maybe we do it from a benefit point of view as opposed to, what's the primary care system definition, then we'll get some answer and some level of accuracy about what does universal health care look like from a cost perspective, right?
Matthew, did you have a comment?
I agree with what Mary laid out and the questions that Christine laid out about or raised can be answered by that survey. It can have various scenarios. Well, we're assuming primary care encompasses this universe of services, but some people think if we expand that definition, that can all be addressed in that. So I think to Jennifer's point about asking the right question, I think Mary framed it well, and those questions can be open-ended a little bit. We don't have to answer the question before we propose it.
Christine?
Sorry, I think I forgot to lower my hand.
And I know we're running out of time, but I'm going to make a suggestion that from what we've heard of this conversation and the input that we are getting, and I know we're in our final minutes, that staff can take that, organize it, turn it into an idea that can be taken to the commission, circulate it via email, make sure we have FTAC's blessing on that, and then we could take that idea to the commission in June, and that keeps us on track with the schedule.
Any concerns about that approach? I think we're happy to have a resolution. I think it's important to have it come back to us, and then if that would give any committee member an opportunity to raise concerns, or if there's something you go home and think about tonight that we didn't get to talk about today, it'd be an opportunity to bring that forward.
And just, to tell you the timing, the commission meeting is June 18th.
Okay.
And just be careful of open public meeting. We don't want to
exactly
so I just would, I guess, as long as we're individually giving information to staff, then and then whatever is presented in an open meeting with the universal committee would be safe. So I have to go.
Yeah,
So
say
sorry.
staff can synthesize and recirculate as long as it just comes to us and doesn't go to the whole crowd. Thank you for bringing that up, Sarah.
Yeah. Thank you, Sarah. And thanks for your participation today. Okay, Roger, do you want the last word?
Yeah, I do. Thank you. So Matt, I agreed with you, Matthew, about, not asking consultants to do the work we can do. I quite agree with that. So my question back is, I would still argue that for painting a landscape for the commission to understand future financing is to have a decent sense of how our revenue sources are today. And you've indicated rightly so that we have that information. So is that something Department of Revenue could put together for us?
I'm not volunteering to do that, but that is part of my role on this commission. But I'm not going to do it in a politically suicidal way. We need to, in my view, determine what these programs will cost. It is a political question, and it is every year. The last two governors came to us and said, we need money. Department of Revenue, find us all this money. And we go through these exercises of trying to find money, and we still can't balance the budget. And I think it will be political suicide for this commission to get into how we're going to pay for it. We can talk about what the cost will be and be honest and say, this is a system we designed. We think it will work. This is what it will cost. These will be the benefits. These will be the risks. We can do all of that with economic and fiscal analysis. But once we get into the question of start proposing, and we think the insurance premium tax should be raised by 3%, we're dead in the water.
Okay, I think I'd like to leave it there. And we will come back to complete this discussion at a future meeting, because figuring out what this costs and how it gets paid for is going to be not something we resolve today. We will continue to work on that.
Thank you for cutting it short.
You're welcome. And thanks everyone for really great discussion. Really thank you to the staff for really excellent preparation and really helping us get through these really hard topics, and incredible, excellent discussion today. So thanks everyone, and we'll see you next time.
Thanks everyone. Thank you. And thank you, Audrey, for making the meeting happen.